Older adults can experience changes in capacity to process medications, like I just alluded to that a couple slides ago, and they're at a high risk for drug interactions, which put them at risk for substance use disorders. So, you know, as you get older, things change, obviously, but your organ systems change also. So it's not just like the outer changes that we observe in aging. There are changes in the way that your liver works. There's changes in the way that your kidneys process medications. So again, if you're being prescribed a medication long term, and people are living longer and longer, if you look at statistics, the older adult population is like the largest growing subgroup population in America right now. If you're prescribed like a cholesterol or blood pressure medication when you're 40 years old, and the past life expectation might have been 65 and people are living to 85 now, that's a difference of 20 years. So expecting that medication is going to work the same from the time that you're 45 to the time that you're 85 is not realistic necessarily, but a lot of doctors aren't necessarily checking in about that. Or if you switch doctors, or if you change insurances. And speaking of insurance, one thing that I want to preface, that Charles and I both want to preface, is that we're not insurance experts, and we're going to talk a little bit about resources, but that's one thing that this isn't necessarily about, is like what insurance goes where for different treatments. So this is another kind of scary one. Nearly 17 million older adults are prescribed sedatives. Benzodiazepines are a type of sedative, and they're the most commonly misused and abused prescription medications. So these are things like Xanax, Klonopin, Ativan, Valium, Soma, Milton. I mean, we have a whole list when I was working at Dunn Farm of benzodiazepines and benzo-adjacent drugs. So these are dangerous medications in general, and they have been wildly overprescribed for a long time. But again, to go back to the idea that investing in older adults' health care and the idea that older adults can recover and get better, benzodiazepines kind of can be used in the other direction if you want somebody to like calm down, or you know, because they're an easy solution to like feel better, or deal with anxiety and different feelings that probably should be dealt with in other ways, either through mental health care or different kinds of medical care, or things like that. So it's important to know that I think part of the contributing reason why that number is so high is because a practice in the medical field for a long time, and in the healthcare field in general and in society, is that we kind of throw medications at older adults instead of looking at how we can use treatment and invest in their recovery and in their betterment health-wise. So that's kind of a scary statistic, and that's from SAMHSA that's coming from. So older adults are hospitalized as often for alcohol-related problems as for heart attacks. So that, when I read that, I was like, that sounds ridiculous. But when you think about what I think of when I think of an alcohol-related problem, I think of like alcohol poisoning, or like being super drunk and like not being able to like breathe properly, or, you know, working at a detox center for a long time. When I think of an alcohol-related problem, I probably think of it a little bit differently. So this can mean things like alcohol, like peripherally alcohol-related problems also. So maybe you had a glass of wine and it's only one glass of wine, but it makes you kind of get a little bit dizzy when you take it with your blood pressure medication, and then you fall. And and this is probably, it's hard to collect this data if the doctors and hospitals and healthcare professionals aren't asking the right questions, but that's kind of scary, because you think of like a heart attack as like, you know, a more normal thing for an older adult to be going through than having an alcohol-related problem and being hospitalized for it. So this, and again, this is from SAMHSA, so this is like a big source. This isn't some small study that that's reporting this. So this is kind of where I segue into at the doctor's office. So, like I said before, the healthcare profession plays a huge role in what addiction looks like with older adults. So they're often prescribing the medications that end up being problematic for older adults, and that is true for younger people also, but if with the attitude of not necessarily providing treatment to rehabilitate someone or bring them back up to a functioning level, this can often be problematic, and that's kind of, like I've said before, kind of the attitude that we've had with treating older adults. So with that, these are basic facts about seniors and medications. So older, and I said this before, but I think it bears repeating, that older adults are more likely to be prescribed multiple medications, many of which are taken long term. And that's by multiple prescribers, and again, this is something that's like very important to know and kind of to be expounded upon. So again, this is another scary slide to me when I read this. 90% of seniors take one medication, 40% take more than 5 medications, and 12% take more than 10 medications. So I personally take like 3 medications, 2 of which are over the counter, and it's hard enough for me to remember to take all of those at the same time every day. Even if I set an alarm on my phone twice to remind me and my computer reminds me. That is pretty straightforward. But again, working somewhere where we're managing people taking medication, some people having like 17 or 20 medications, and they're all prescribed for different times of day. You have to take them with different foods. You have to not take this one with citrus. You have to take this one with milk. You need to eat this much. You have to take this one on an empty stomach. So that can be difficult enough with 1 or 2 medications, but with almost half of older adults taking more than 5 medications, that can become daunting, to say the least. So, and then 12% take more than 10 medications, so that's, again, a lot of medication to be managing, especially when you don't necessarily have the assistance necessary to be able to manage that medication. So medication management can play a lot into kind of what addiction looks like for older adults. There are services that can help with this, but getting in-home services or getting extra services costs money, and insurance coverage is troublesome when it comes to things like that. There are resources like pharmacies can sometimes blister pack medications, like CMH blister packs medications, which seems to be pretty helpful for some people. When I say CMH, I mean community mental health, by the way. But this can also be a place where social workers and caregivers and people who are kind of in the periphery of medical treatment that aren't necessarily the prescribing doctor can come in and help with medication management, because again, a lot of older adults become accidentally addicted to medications that they're prescribed. So that can be problematic, obviously. So those over 65 comprise 12 to 13% of the US population, and this is rising, and consume roughly 30 to 40% of all prescription medications. So if you can imagine that, like the slide said earlier, that 17 million older adults are taking benzodiazepines, that can obviously, that's a large number. So 30 to 40%, so I mean almost half, if we're taking a stretch, of all prescription medications that are given out in this country are given to people over 65. And we all know, or hopefully we all know, how big the pharmaceutical industry is. There's ads everywhere. There's a new medication every day, or more than that. So I think, again, it's important to understand kind of the breadth of the problem here, and how much older adults are being exposed to a lot of medications taken long-term by multiple prescribers. You switch doctors. Again, there's this huge lack of communication, kind of compounded by Just the simple fact that older adults are, as you age, you're going to have medical problems, and those medical problems are typically going to be treated by medications. So this is drug interactions and risk factors. So I touched a little bit kind of on drug interactions. So harmful drug combinations can produce side effects like fatigue, excessive sedation, coma, which is, I feel like should be probably in a category of its own because that seems pretty serious. And then milder effects, and again, milder is kind of gentle. Effects of drug combinations can be changes in sleep, changes in appetite, changes in anxiety level. So kind of these things can happen because of drug interactions, but if you look at this list of different symptoms, this can mirror a lot of issues that are looked at as like getting older, or changes with dementia, or changes with, you know, that happen that aren't necessarily related to problems that have to do with medication. So I work with somebody currently who was on I don't know how many medications, but she was presenting with a lot of these symptoms. And her family was like, oh, like you must have some dementia happening, or you must be getting Alzheimer's, or you know, whatever that they were thinking. And they were coming from a place of love. They weren't trying to like put their mom into a nursing home. But that's what ended up happening. They went to the doctor and they were like, she's having all these symptoms like memory loss and changes in sleep, appetite, sedation, and eventually she ended up in a nursing home. And as I said just a second ago, she works with me now, so clearly that's not where she ended up. But they did a change in medication with her because somebody along the way in the medical field decided to try that, and she kind of came back and is now working at U of M. So that's, and she, I don't mean for it to sound like that, but she's like a great, like integral part of like what we do, and she is like a very vital person, and you know, I interact with her on a daily basis, and it's kind of terrifying to think about somebody who's like active and vital and you can have a full conversation with and like holds a full-time job, being put into a nursing home because they assumed that she had dementia when it really was just like a wrong combination of medications. So this can obviously be more severe than just being anxious or like not having a great appetite, which you know, I wish that I could take some combination of medications that would prevent me from having this appetite. So risk factors: few older adults use mood-altering drugs recreationally. So I think this is important to note here. And again, working at a drug treatment center for a long time, I've seen plenty of older adults who are using street drugs or illicit drugs, whatever you want to call them. I don't know what the like correct PC term is for the drugs that people are taking, because we don't want to stigmatize any more than is already happening. But not very many older adults are out on the streets, you know, like copping heroin or smoking crack or doing things that we typically associate with like younger addicts. It definitely exists, so I don't want to discount that. But when you look at addiction in older adults, most problems stem from unintentional misuse. So this can look different for everybody. So taking extra doses, missing doses, not following the instructions, using expired medications, not being aware of side effects, sharing or borrowing medications, mixing medications, or drinking alcohol while taking some medications. So all of these things can lead to obviously medical issues, but also can cause someone to become unintentionally dependent on a medication. And then again, looking at things that come along with older adulthood and maybe memory issues, and maybe there are some dementia issues happening, unintentional misuse can happen very innocently. So that's the word unintentional is important here, because if somebody is struggling with memory issues, or somebody is struggling with mental health issues or certain medical issues, doing one of these things can become very easy. So you took a medication in the morning because you don't have all your pills put into like some nice blister pack that some pharmacist did for you. And then you take a nap, or you know, have lunch, or you have a phone call, and then you know, it's a few hours later and you're like, did I take that medication? And you're like, but you know, it couldn't hurt, let me just take another one. Especially if it's a medication like Xanax or Klonopin or opiates that, you know, don't have an unpleasant effect for most people when they take them. So these kind of things, while on their own, or if they happen once in a while, like they probably happen to all of us once in a while, don't necessarily make someone an addict if they like accidentally take another pill one day, but these are kind of like the small steps, like the sands in the hourglass, that can make it, can turn into a bigger problem over time, especially, again, to reiterate that older adults are taking multiple medications for longer periods of time. We're not talking about like 10-day Z-packs here. So when you're mixing a lot of these medications, and when you're dealing with generics versus brand names, and you go to 5 different pharmacies because you can't, like, this pharmacy is cheaper to get this medication, and this pharmacy has a discount card, and this pharmacy, which kind of speaks to a larger equity issue that we're not going to get into today. But I mean, it's easy, unfortunately, if you were taking 10 medications and getting them from 5 different pharmacies, and they're coming from 7 different doctors at 3 different hospitals and 4 different health clinics, which is not, I'm saying that and it sounds crazy, but it is like fully accurate for a lot of people. That can obviously be very problematic, and lead to unintentional misuse, unintentional addiction, overdose, death, coma, really serious problems. So more risk factors, I've kind of touched on a few of these already. Multiple physicians prescribing multiple drugs, which is called polypharmacy sometimes, if you've ever heard that term. Inappropriate prescribing, so wrong dose, wrong medication, and this can mean a mistake that a doctor or a pharmacist makes, but it can also, again, going back to like the 6 doctors at 4 hospitals prescribing 12 medications, a lot of times the right hand doesn't know what the left hand's doing. So can be complete lack of communication, miscommunication, and there's not, unfortunately, some magical computer system where everybody can check everything that you're taking and know what all the other doctors that are involved in an older adult's life are doing. So instructions and package inserts written in small print or confusing language, I think, I hope we can all understand that. I don't even bother, because even at a younger age, it's hard for me to read tiny print and find which language applies and things like that. This can also kind of speak to like literacy issues, which I think is another big thing if you're in the health profession, that we're finding out it can be obviously problematic in accessing healthcare. If you have literacy issues, or I run into a lot of older adults, and I definitely don't want to generalize because I run into a lot of older adults in the other direction, but there are a lot of older adults who didn't necessarily finish high school, or didn't necessarily have a huge emphasis placed on the importance of education, and knowing beyond basic reading or writing your own name. That wasn't a big part of their lives, and they've been able to kind of fly under the radar, and again, if we're not asking the questions, and the doctor sees you for 10 seconds in his office, and but still charges the whole amount to the insurance, that can be problematic. And assuming that somebody can read the medication bottles, and assuming that somebody can pull out like the 35 pieces of tiny paper that come with every prescription and read them and make sure that they know. But also, again, knowing like there are older adults that I run into who are taking the same medication, a generic and a brand name, prescribed by different doctors, and they didn't know that they were doing that. And luckily they weren't like, it wasn't like the worst medication that you could be doing this with, but that's not a great situation, period. So failure to tell the doctor about over-the-counter medications. Vitamins, herbal supplements, things like that. A lot of people, and this again doesn't just apply to older adults, over-the-counter stuff and herbals and magic teas and suckers that Kim Kardashian sells on Instagram. It's important to know that it's important to tell your doctor what you're ingesting. So if it doesn't need a prescription, it doesn't mean that it's not a real medication. It doesn't mean that that it's not interacting with the medications that you're taking. So that's important to know, and it's important to tell your doctor that you're taking an over-the-counter medication. And again, to kind of speak to older adults specifically, there are a lot of older adults who came up in a time when you would take like an over-the-counter medication or maybe an herbal medication when you were sick with something, and they don't necessarily even think of it to tell their doctor that like, hey, I'm sick and I'm also taking this herbal supplement. And again, these are harmful interactions that can happen. And again, I touched on this earlier too, memory problems that make it difficult to keep track of medication schedules. So not only just schedules, but medication management in general. And not everybody has access to like a live-in caregiver or proper health care in general to ensure that their medication management is happening like it should. So again, that speaks to like a larger societal issue with the healthcare system, but we're not here to talk about that today. So missing instructions as a result of hearing or vision problems, memory problems, or language barriers. So again, this is where a lot of us can come in as like peripheral care people and people who work in the healthcare industry that might have some more time and interaction with our clients and patients and loved ones, that making sure that they, even if they can read and don't have literacy issues and don't necessarily have vision problems, a lot of people are intimidated to ask the doctor for more information about the medications that they're taking. Language barriers is another one, assuming that somebody, that English is their primary language, or that they those booklets that we were talking about come in 100 different languages for a reason, because a lot of these drugs are being prescribed to lots of different populations in lots of areas. So, and at most large health systems, like U of M specifically, in my department is the whole interpreter services, and there are, it would be much less of a hassle to ask for an interpreter than it would be to end up in the emergency room because you mismanaged or mistook a medication and didn't ask because you were concerned about or embarrassed or not comfortable asking the doctor. And I say doctor because that's who's prescribing the medications often, but your pharmacist can play a huge role in medication management also. I worked at a really great pharmacy in high school that was like a little gift shop, and it was wonderful and very like Andy Griffith, and he knew everybody and he helped everybody and he knew everything about medications and what you shouldn't take with this, and and unfortunately we were bought out by Rite Aid because that's how things work now, but so there's a lot less of that kind of personalized care at pharmacies and in healthcare settings in general, but your pharmacist is another person. A lot of people have more personal relationships with their pharmacists maybe than their doctors. You can tell them all the medications that you're taking, because that's part of their training, and part of their job is to kind of be a second line of defense. If your doctor does something that doesn't necessarily look right, your pharmacist can catch that, and you can also ask your pharmacist about things like that. Or ask your pharmacist about interactions with over-the-counter medications, or ask about interactions between medications that you're being prescribed by multiple prescribers. So they're an important resource that I think is often overlooked, but it is available. So these are some do's and don'ts, kind of as far as medications in older adults. So some do's are to understand all instructions before you take a medication, even if it means asking your pharmacist, even if it means asking your caretaker, or asking a family member or friend or loved one or social worker, or someone who works at the senior center where you frequent. Sorry about that, to read over some strange instructions. So that's really important, obviously, to know what you're putting in your body and what you're taking. So follow instructions exactly. So again, this can be difficult if there's like language barriers or vision issues. Keep all medications in one place. So that is an important idea instead of, I've seen so many houses at home visits that I've done where there's medications kind of strewn all over the place and they may or may not be taking these, or we had so many clients come in who had like their little bottle that they would have like 700 different medications in, and they'd be like, I just like pick a couple of these out and it's usually okay. So it might be like easier to just have like one little bottle with like 70 different medications in it, but it's obviously can lead to a lot of confusion because so many pills look exactly alike, and some pills like shouldn't be touching other pills. That's something that I didn't even know. I remember, again, working at that pharmacy in high school, like the female pharmacy techs weren't allowed to touch the male hair loss pills because they could have like huge, just the dust from those medications could have huge interactions with their female systems. So that's, I don't know how else to put that, but it's important to not be mixing things and not be, disorganized for the sake of what you think might be easier. So keep medications, again, not mixing things. Keep medications taken by mouth separate from topicals. Check expiration dates on all prescription and over-the-counter medications. I know that, especially if medications cost a lot or it was inconvenient to get them, and we think that like, oh, I didn't finish these antibiotics, I should probably just keep these for the next time I'm not feeling good. Or, keep this medication like, oh, it expired 6 months ago, but I'm sure it's fine. That can be problematic because as medication ages, its effectiveness goes down. So it's not always a good idea to take expired medication, even if it is more cost effective. Organize a system for taking medications, like a chart or a plastic pill organizer. They make pill organizers now that like have like 100 different slots, and we'll have like 30 throughout the day to tell you. I had a client who had literally like a wall-sized dry erase board that she had like a whole chart that her caretaker had done for her, and that worked for her. So, I mean, it's important to take the time to find a system that works, even if it feels inconvenient or you don't want to bother someone. It is important enough. So ask your doctor about your medications. So ask about interactions, ask about polypharmacy, multiple prescribers, multiple drugs, and facilitate communication between healthcare providers. So I talked about this before, but again, it bears repeating. Not every doctor knows what all the other doctors are doing, even in the same health system. So it's important to get your discharge paperwork, or at least sign the release so that your doctor can ask the other doctor what they were doing. So that's important to know. And again, ask your doctor, but also ask your pharmacist, because they can be helpful in this arena also. So these are some don'ts. So don't drink alcohol in combination with other drugs without asking a doctor or pharmacist. Don't give, take, or trade medications with anyone. Even if it's more cost effective, it's not worth it in the end. Don't transfer a drug from its original container to another container, except for pill containers to avoid confusion, kind of what I talked about with like the 70 pills in one bottle. Don't save unused medications for use in the future. If you get sick again with the same thing, it's still a good idea to ask your doctor if you should take the same medication again, because for many reasons. But if they want you to take the medication again, they will prescribe it again. Don't take medications in poor lighting. Again, this speaks to the vision issues, but if you can't see what you're taking, then it's probably not a good idea to take it. So don't stop taking medication without talking to the prescriber. So this is important. Also, because they're prescribing you to start taking it, usually with instructions, and it's probably a good idea even if there's adverse side effects, and it's important, that's another important part of this, is like, what side effects are normal? What side effects should I look for to stop this medication? When can I stop it? Ask those questions, because I've met a lot of doctors, and I don't know any of those doctors that would rather you end up in the ER or end up dead or in a coma than take an extra 3 minutes to explain how to take your medications. And the same with pharmacists. I mean, most people are out for the good of their patients, not just the paycheck. So that is important also. So questions to ask: what's the name? Why am I taking it? Is it really necessary? So again, a lot of doctors, I talked about this earlier, will throw medications, especially at older adults, because they want you to get out of their office, or they don't think that it's really worthwhile to treat you and get you into a better place in your health. So is it necessary is a legitimate question that you can ask your doctor, and they should be able to answer that question without too much struggle, because otherwise they shouldn't be prescribing it probably. What are the side effects? Which should I report right away? How often? What time of day? What food should I take with it? What food shouldn't I take with it? What should I do if I miss a dose? Should I take it with food? Any special precautions like food or alcohol or driving? When and how can I stop taking this medication? And is there any chance for interaction with other drugs that I'm taking? And again, to kind of underline all of this, it's important for your doctor to know all the medications that you're taking. It's important for all of your doctors to know what all the other doctors are doing. It's also important for your doctors to know whether or not you're drinking alcohol, even if you don't think that it's a lot, even if it's 1 glass of wine 2 days a week. They need to know, and again, this leads to kind of like the stigma and shame that come with addiction. If you're using illicit substances or whatever you want to call them, nobody's going to come and take you or your loved one away in a straitjacket because you told them that you're using substances. There's not enough treatment centers to put all those people anyway, unfortunately. So nobody's, trust me when I say nobody's dragging people and forcing them into treatment besides maybe the MDOC, but we're not here to talk about that. More ways to avoid medication misuse: get help reading and understanding medication inserts and instructions. Ask your doctor to explain carefully what you're supposed to be doing. Tell your healthcare providers and pharmacists everything, and ask for help if you need help with communication barriers. So this is kind of where Charles is going to take over, but just real quick, I kind of want to summarize again that addiction is real in older adults. Older adults have hope, and providing older adults with resources and treatment for addiction does work. But it's also important to know kind of the unique ways that addiction presents in older adults, and also what a huge role, I hope I got across what a huge role the medical community plays in what addiction looks like with older adults, because it's not necessarily like the heroin or the crack or the illicit drugs that we see on the news or when we talk about addiction. That does look like that sometimes with older adults, but oftentimes it's accidental usage or usage that's in conjunction with medical care. So it's really important to keep those things in mind, especially as social workers and as providers and as caregivers and loved ones. So with that, I will turn this over to Charles, and we have to do a quick little mic switch.
2 good things. We got a lot of good information, and the other good thing is we're 2/3 of the way through the presentation. So how's everybody holding up? So I'm going to talk a little bit about resources here. When Matt and I put this presentation together, what we found that was interesting was that despite the growing need for treatment for this population that we're talking about, there was no resources, and treatment on demand was very, very limited, which we found very, very shocking. Full disclosure, when I went to school, I started off in mental health and youth and family. And then I noticed that there was a track for aging and family. And at that point, I started thinking about my mother, when she passed away. And I remember how involved I was as her being an older adult and facilitating a lot of her treatment, a lot of her care. And hadn't I been there, I was frightened to think of the care she would have gotten. And it was also interesting that in the School of Social Work that only a quarter of my cohort was actually in the track dealing with aging in place. It was more sexier and fun to be in youth and family or mental health. So with the baby boomers actually aging, and also with the silent generations before the baby boomers, as Matt mentioned in his part of his presentation, that's a huge segment of our population that's going to need some help and some guidance and some care. So it was a no-brainer for me to switch tracks and go into aging and family. So we're going to talk a little bit about what's out there for people who fall within that population. And we're going to talk a little bit about treatment, inpatient versus residential treatment, and detox. So a little bit about detox. And when we talk about here, we're going to just give you what's available actually in this area. And we try to do some research, and we found it very shocking that in southeastern Michigan, it was very, 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 very little resources or treatment facilities available, specifically for those ones 55 and older. Now there's treatment centers around, but it wasn't really specifically made for those ones within that age group. So when we talked about detox, we talked about medical detox versus non-medical, acute versus subacute. And in that setting, pretty much symptoms are monitored, medications are administered sometimes if needed, and the whole purpose of medication is to provide comfort, to help with some withdrawals that could actually be severe, prevent seizures, and that typical stay in those environments is usually 3 to 7 days in length. And also outpatient services too are available for those ones who are seeking help with their loved ones or themselves. And typically in the outpatient environment, it's pretty much the lowest level of care. People tend to live at home independently, and they can go there for therapy. They have groups versus individuals. The intensive outpatient can be anywhere between 3 to 4 hours per day, multiple days per week, or enhanced outpatient can be 1.5 hours to 1 to 3 times per week. And often the client is encouraged to come there once a week or once every 2 weeks. And they have an opportunity to work with a therapist who actually run groups or can provide individual sections. Then we have inpatients and residential treatment. Now in an inpatient setting, it's generally like in hospitals or a medical kind of setting where they actually administer some kind of maybe medication to help. An example of that would be something like Brighton Hospital. They're known for inpatient settings where they have a nurse or a nurse practitioner or PA around the clock to really help with some of the symptoms and just to make the stay there a little bit more comfortable. Then we have a residential kind of setting for treatment, and that's something typically what Don Farm does is a non-medical setting where our clients can come there and actually, if need some type of medication, it's not really administered to the extent that you would find it at Brighton, but administered to the point of making them a little bit more comfortable while they're there. And generally some of those stays are 7 days, 14 days, 21 days, and 28 days. Now, it's interesting that we have these days here. I'm often reminded of the length of stay when it comes to certain professionals. For instance, like pilots and those ones in the healthcare profession. You would never see them go in a 20-day treatment center. We call those somewhat spin drives where they come in and they go out. And quite frankly, I don't know if I want a doctor or a pilot flying my plane this guy with treatment in 21 days or 28 days. I pretty much want them to be in there for a long-term period of time with a monitoring piece attached to that to ensure they actually engage in that recovery process. But typically, this is what you see in most of this type of setting right here. And a lot of that is predicated upon insurance. You know, with the managed care back in the 80s, it really limited a lot of the time that they would pay for individuals going in a residential type setting. And again, you know, sorry, again, we can go back here, then go back, sorry, right here. There are increments of 7 days, and again, often that's dictated by the insurance companies. You have longer treatments, which the site that Emily and I work for, you can be there for 3 months, 6 months or a year plus, and that's generally the highest level of care. And it's actually the most costly form, of treatment actually that insurance would pay for. You think about some places where individuals are in treatment for 90 days or more, and in some places like in California where your average cost is $500 a day, you can see how that can run up a tab, and why in some cases insurance companies are very reluctant to actually pay for those services. So which level of care is right? There are some factors that we thought that you might want to consider in making that determination, either for yourself or for your loved ones. And you have various levels of care, and usually that's like a LOC done by an intake coordinator or experienced therapist who actually determine what level of care is appropriate for the individual. Maybe your loved one or maybe someone you know may not need to be in treatment for a long time. Maybe they just need some type of outpatient services, but that's actually done by the intake worker who actually would do a question over the phone to do what is actually needed. And again, that depends upon the severity of the addiction and the ability to commit to entering treatment. Some people can't take time off from work, in order to go to treatment to get the care they need. Some people who work for agencies may want them to go and get the care that they need for those treatments or symptoms that may be impacting their performance. And also cost can be a factor. And again, insurance coverage and the ability or availability for treatment. So what do you do if you live in Washtenaw County? Well, we have two core providers here in Washtenaw County. Home Division and Don Farm are the core provider, which means that they have been identified by the funding stream to really provide substance abuse treatment for those ones who are experiencing problems. And the way that is determined what client goes to where is generally by their birth month. If you're born on the odd month, then you actually would be referred to Don Farm. If you are born in even month, then you will be referred to the Home Divisions. And there are some nuances too that could determine whether or not, if you go to one of those two facilities, a person may have a long-term relationship with Don Farm, but maybe an even month, and there are some things in place that we can actually negotiate to have them come to us for services. Also, felony probations and veteran status could mean a difference in referrals. The Michigan Department of Corrections and the VA is very involved in some of their clients, and they generally would pay for treatment too for those ones who are coming to them for services. And they may also end up paying for services for either one of those facilities as well. The Don Farm and Home Divisions can also provide referrals to a higher level of care, particularly if someone coming to us with a disability and they can't actually be there physically. We can make referrals out to another level of care and bill Medicaid services if applicable in those cases there. And also, all this also applies to those ones who are uninsured. Having Medicare or being dual enrolled can also change the scenario of this dynamic as well. So treatment centers that accept Medicare in our areas we identify as UMAT, and there you can get outpatient service or intensive outpatient services. Green Book, which is here in St. Joe's campus, you can get outpatient services or intensive outpatient services. St. Mary's in Livonia, you can get detox services and inpatient services. And IOP as well? Thank you very much, I appreciate that. Brighton Center for Recovery, these are the services that they provide. Detox, inpatient, outpatient, and intensive outpatient services. Huron Oaks in New Baltimore, dual diagnosed treatment. This is a person who may have a mental diagnosis as well, a substance use disorder. Detox, inpatient, and outpatient and intensive outpatient services. Henry Ford and Jackson, you can get a residential, outpatient, intensive outpatient. Arrowhead Behavioral Health in Ohio, you can get detox and inpatient services. And when I was doing my internship at Turner Clinic, I had to go do a site visit, and I found this as one resource that I was able to provide to the clients there. And this is actually located in Chelsea. It's the Older Adult Recovery Center. And is such a fascinating place is that it provides intensive outpatient and standard outpatient treatment for the clients who come there. Their outpatient program is offered Monday, Tuesday, Thursdays, and Fridays from 10 a.m. to 12 p.m. And at that facility, they have what I thought was interesting, peer counselors who actually were participants in the program, who have come back and actually become mentors and help those ones who are having problems with substance abuse disorders or alcoholism just to get to AA meetings, more like a peer support to help them through that initial kind of engagement with that particular facility. The program also places emphasis on providing adults with substance abuse education, recovery tools, strategies for maintaining long-term recovery, and continuous support once they complete the program. They provide service to adults of ages 40 and older, experiencing problems with abuse of alcohol, prescription medication, and or other drugs. The guy there is just really a dynamic guy, and I got an opportunity to meet some of the peer supports were there, and they really had a passion for that population in which they were privileged to be of service for. And then I also did my placement at this Huron Valley PACE. Now, what's so unique about PACE is it's this national initiative that actually provide what they call an integrative approach to helping older adults with multiple problems. For instance, if you were going there for services, you'll be able to see a nutritionist, you'll be able to see a doctor, you'll be able to see someone who can help you with PT and OT. They provide transportation, they provide a day center. On one side, they have those ones who maybe experience dementia. On the other side, they have activity center. So everything is under one roof when it comes to this integrated approach to helping those ones who fall within their category of being approved for services. Now, what they didn't have, and I was actually in a position to help, they didn't have any service for those ones who was experiencing problems with drugs and alcohol. And every morning we will have this team meeting where we would talk about clients who either called in the night before or the clients who were on that caseload. And every now and then we'll get a client who was experiencing problems with either drugs or alcohol. And I often found it very disheartening when the stigma that Matt talked about earlier, that some of the professionals around the table would have towards one of their participants in their program. And I often would question them about, has anyone ever, talked to this individual about having a substance abuse disorder problem or a problem with alcohol, or has anyone ever done an assessment? And a lot of times the answer was no. But they were very, very quick to either, one, disenroll them for the services, or two, provide judgment about those individuals. So I was able to get a couple groups going there, and I was able to get someone from our agency to go in and do an Addiction 101 that really provided some education for those ones who were participants of that program, and many to our staff who was in there as well. So Huron Valley PACE is located in Ypsilanti. They have one in Jackson, they have one in Detroit. It's a program that's pretty much duplicated all over the country. For our older adults who are 55 or older, who have ongoing health care needs and live within the service area that particular PACE agency is located at. I think in Ypsi, it serves Ann Arbor, it serves parts of Livingston County, the end of Wayne County, the west side of Wayne County, and down in Milan. So that's the geographical area that they actually would send a van to bring them back to the center every day to give them the services that they provide. Services at the day center and the community and in the home. And the whole objective behind the PACE model that I really appreciate is there's a strong emphasis on aging in place. And what I mean by aging in place is the whole premise behind their agenda is to allow the older adult to live in their home and not put them in a adult foster care facility or something like that. And to me, I think that's amazing, because you think about all the capital and time that older adults have invested in their house or their home, now to snatch them out and put them in some kind of assisted living facility that really contributes to the whole aging process and the depression that Matt talked a little about earlier. But to keep them in their home where they're familiar with their surroundings is a huge benefit. They will even go in and modify the environment so they can to go to the bathroom or cook for themselves, whatever is needed to keep them in that environment there. They have a physician and primary care team, 24/7 medical coverage. They can call the number at any time of the night, and Huron Valley Ambulance will be right there to facilitate any medical needs or care they may have. Coordinated consultation with community physicians as necessary, so they have alliances with St. Joe's, alliances with the University of Michigan. If there's kind of a specialty a problem that may arise that's beyond their scope of services, they have connection with those facilities to make sure that that care is actually given to that particular participant who's there. Unlimited skilled therapists, again, doing that team meeting that we have every morning. We sit around the table and we talk about what the care is for that individual, and we facilitate that on the spot that day the next time they come in for treatment. And of course, medical transportation if needed. So there's a lot of overreaching issues that Matt and I discussed or found out, and it was really, really sad that there wasn't, other than the place in Chelsea was the only addiction treatment in Washtenaw County that specialized, specifically treats older adults with substance abuse disorder. There was no other place that did that. Now again, they can go to Don Farm and Home Division, but they don't specialize in just that population that's 55, 65 and older. They become part of this amazing community there. But the recovery center in Chelsea was the only place that actually we saw within the southeastern Michigan that specifically deal with that population. And other programs who accept older adults don't always tailor programs to their unique needs per se. Don Farm and Home Division are very accommodating, but older adults have specific needs, that they have to be adhered to. But there was no program that we saw that actually did that. So we provided a couple of numbers that we thought that as social workers, we're always looking at how we can provide or be advocates for those ones that's in our care. We look at the inequality that sometimes those ones in that population may experience. So here's a couple of numbers that we thought that you actually can call your senator or your state representative and say, look, we need to have more facilities here that specifically cater to those ones of the baby boomer population or those ones in that silent generation before those ones in that population, the baby boomers, to give them services. So advocate for programs for older adults in general, but also addiction treatment for older adults as well is what we think is needed. So, told you it's going to be quick, right? So that's it for us as far as research. So we're going to spend a couple of minutes answering any questions that you may have, if any. And
so he asked if an older adult is, basically how do you define what an older adult looks like?
Well, the age. Well, it depends. 65 is what you're eligible for Social Security disability, but the programs that we found, or for instance, PACE is 55 and older, and the center in Chelsea, it can be 40 and older. So it varies depending upon the agency that you're applying for service for.
It does vary a lot. I will say that, like at my agency, it's 50. At the Older Adult Recovery Center, it's 40. For a lot of like federal programs, it's 65. Some places that are assisted living or independent living facilities, it's 62. So I think to answer your question, there isn't an answer to your question necessarily. It depends a lot on what kind of services you're looking for. And again, this can kind of, it's evolving kind of as we look at what an older adult looks like and what kind of care needs that they have. There, like Charles was saying, there's a lot of specialization when you go to social work school for like children and families, and there's older adults. But there's like a lot of time between when you're a baby and when you're, when you're 85. And we kind of probably need to be better. The healthcare system needs to be better at maybe parceling that out so that people are getting the best treatment. But also, on the other hand, individualized treatment is important also in making sure that we meet the individual needs.
Right.
But there isn't like a set number for what older
Right.
adult means. A lot of the research that I was doing is 65 or older because, again, that's kind of the old way of defining what a senior is or what an older adult is. So yes, there is. And what he asked is there research that kind of indicates the differences in success level between younger adults and older adults, or younger people and older adults, when it comes to addiction treatment? Yes, there is research on that I found. I didn't think to include it, so thank you for calling me out on that. I was able to find that. I mean, one thing, I don't have any numbers right off the top of my head, but what I found in my research is that older adults, they have a lot of willpower, actually. So in a lot of studies, they found that older adults, when you look at kind of like the dismal percentages and dismal numbers of kind of relapse and the rate of success with addiction, which is, again, a very gray thing to try and measure what success looks like. Older adults tend to do very well when they are treated with respect and like there's a point in treating them. So I mean, overall, and I know you personally, so I can send you some studies if you're interested, but there are research available to kind of prove that it is worthwhile to help treat older adults. So.
And one thing just to piggyback that is that when we deal with older adults and substance disorder, be very, very careful, because you have an older adult who's been taking medication for years, and they've been, like, they fall down and they break their hip or something, and they're given a pain medication. Well, they have this mentality. It's prescribed by my doctor, and they've been taking it for years and years and years and years and years. And in their mind, they don't have a substance abuse disorder issue, So it's kind of hard to treat those ones, or not necessarily treat them, but to do somewhat of a research on them if they're not showing up on treatment doors identifying as having a problem. They don't think they have a problem to begin with. So when you find those ones, maybe from an intervention from their families, who say something is wrong, maybe because of dementia, or Matt talked about having the same medication, or I forgot I took my opiate for my pain, so now you become physically dependent upon it. But in their mind, they don't have a problem. My doctor prescribed it to me, and they tend to look at it through a different lens than we do. So if you can get them in, then you get them in long enough to have a comparison study, then I think that would be an opportunity to really look at some real numbers compared to those ones who are young and those ones who are older.
She reported that there was a major spike in alcoholism in older adults. And I think that it's important, that's probably multifactorial. So it's important to know that, yes, that's true. Addiction is more prevalent now, but also part of that is probably more reporting. So I think, we talk a lot about stigma and shame and things like that. I hope we've done a lot of work in making it more okay to come forward and say, hey, I have these issues. Hey, I have depression. I have a mental health issue. I have an addiction issue, and seeking help. So I think part of that is probably to do with just honesty and reporting. Part of that probably has to do with good social workers asking questions, and good doctors and good healthcare professionals asking the questions, because you don't know if you don't ask. And it's not something that people are necessarily, jumping for joy over sharing until they have some kind of catastrophic health issue, or they reach end-stage liver disease, or any number of things. But again, to speak to a larger issue of the silver tsunami, which I've heard it called so many times, I don't know if that's super PC or not, but like I said before, older adults are the largest growing population subgroup. People are living a lot longer. People aren't just being put into nursing homes for the end of their lives anymore, thankfully.
Right.
And so, older adults are more engaged and more out there, so I think that probably has something to do with that visibility and that going up. So the more older adults there are, if you look at 20% of a growing number, that number is going to grow too.
Absolutely.
So, yeah, it's terrifying overall. She said that there is we talked, I kind of harped on the idea that older adults play a huge role in how the problem came to be. What role do they play in the solution? Basically, physicians and people in the medical community. I mean, that's a good question. I think that, you know, a part of being part of a comprehensive care team and being, you know, the Hippocratic Oath and do not harm and things like that, it's important to ask those questions and just make it more visible and more talked about. But I also think, and you can do a ton of research about I was just at the opioid summit yesterday, where they were kind of talking about new regulations coming down from the state on how doctors are allowed to prescribe opiates and how they're allowed to be dispensed and for what they're allowed to be dispensed for. So again, I hate to be super vague, but it's multifactorial. So I mean, the doctors need to ask the questions. The doctors need to learn. I think all social workers have to do continuing education. There are credits offered here tonight. Like once you get your full licensure and you're out there being a social worker, you have to keep getting those papers to prove that you're learning something. And I'm not a doctor, so I don't know exactly how that works with the medical field. There very likely could be different continuing education things for doctors, and I see doctors at a lot of continuing education events that I go to. But I mean, just being educated and knowing, I mean, if a doctor went to medical school 30 years ago or 20 years ago, things change. And a big part of that is comprehensive care. It's not the 10-second visit where you're asking what the problem is, writing a script, and sending them home. I think it's important that they ask these questions, but once you get that answer, not just being like, okay, cool, I'm going to write this down and put it in your file that no one's going to look at. It's knowing those resources. It's knowing what to do. It's knowing what to do next. So I think that that's really important also. And I think, you know, I don't know what, we think of doctors as being really high-paid individuals, and oftentimes they are. But I mean, if you're going to be a professional and you're going to have a license and you're going to get paid the big bucks, sometimes it's important to bear that responsibility of being able to follow through. So asking the questions, knowing the resources, and also the regulations that change the way that we prescribe medications like opiates, especially, but benzodiazepines too, and things like that. I mean, opiates are kind of like the big star right now, but it's kind of multifactorial how that needs to be dealt with.
And they have a responsibility. I mean, I'm a person in long-term recovery, and every time I go to my primary care physician, you know, he knows I don't drink, but one of the things he asked me is, how many times did you talk to your sponsor this week? How many AA meetings are you going to this week? So if the doctor was to ask the question to the patient, so tell me about your drinking. How often do you drink? I see that you get this prescription refilled quite often. So just being vigilant and mindful and having that interaction with their patients, I think falls into what Matt was talking about as far as I think a moral responsibility they have to inquire of their individuals who come in for services, right?
He asked what, and I still think I'm talking to the wrong mic, but he asked what kind of differences there are between a dual diagnosis treatment center and a regular treatment center, right? I haven't worked for a dual diagnosis treatment center, so I'm going to preface this with that. I don't think you have either, Charles.
I have not, but on a given day, it can be a dual diagnosis.
Sure. And I mean,
right.
most people who are suffering from addiction have other issues that go along with that. There's co-occurring issues. Right. What I do know of dual diagnosis treatment centers is that they are treating the addiction and the co-occurring issues, typically mental health when you talk about dual diagnosis. They're treating them both primarily. And like at Dunn Farm, for example, most of our clients have co-occurring mental health disorders because it comes with the territory, even if it's just situational. Right. But we're very primarily treating addiction per se. And we're not providing the same level of mental health care as a dual diagnosis treatment center. Another part of that is that there are a lot less dual diagnosis treatment centers than there are standardized treatment centers. There's not enough of either. But that dual diagnosis can also speak to different medical issues too, where it's a more holistic approach to the problems, and a lot of times that's necessary. Where somebody's medical problems are as pressing as their addiction issues, or mental health issues are as pressing as their addiction issues. So there are treatment centers that are more capable and differently staffed that are able to treat both of those things concurrently, versus treating one and then getting supplemental care for the others. She asked if there's different issues treating an older adult who's relapsed versus a younger person who's relapsed. I mean, I think I want you to speak to that also.
We look at the stages of changes and all that, the pre-contemplation, contemplation, and action. I think maybe that will have an impact upon that. But as far as how we approach, and Emily can speak to, I don't think there's really no difference in that piece. We treat everybody the same, the age or whatever the drug of choice is. But, sometimes you get an old curmudgeon, I shouldn't say old curmudgeon, that's really a derogatory term, but an older adult, who's just a stickler. I love my wine, by golly, you're not going to tell me. It can be a little challenging, but our approach is just the same. I don't think there's any kind of different way of doing that. We have an expectation that we have for all our clients, despite your age, despite your drug of choice, despite other factors too that could weigh in on that.
I think also it's about individualized care and meeting all of our clients where they're at, but it's also kind of, there are specific issues that older adults face. I covered a lot of them in this presentation, I hope. But I think Charles touched on a big one, which is my doctor prescribed me this, so it's okay. Or my doctor knows that I'm doing this and it's okay, or it's just one glass of wine and that's okay. And that's not an older adult thing, but if you look at the prevalence of medical addiction that's in conjunction with medical care, it's probably a little bit higher in older adults. So addressing those concerns of, oh, well, my doctor told me that it's okay, or a lot of times older adults have their don't think that they're worth it either, because society has told them that they're not worth it. So I've heard a lot of older adults say, I'm too old, what's the point of trying to do this?
That's right.
And that is something addressed and is probably unique to an older population. So then that's not just a stigma that healthcare professionals carry, it's a stigma that people carry inside themselves.
And family members have the same kind of thing. Well, Granny is 90, let her drink if she wants to drink. And that's really sad, but that's the kind of thing they have. All right.
If anyone has any other questions, we'll both be here for a little while afterwards. So